Hello, colleagues across the world. Good morning, good evening, good night, wherever you are. I'd like to thank you for joining us in the third of a series of webinars honoring World AMR Sepsis Awareness Week. This is the third in a series also of the Global Sepsis Alliance seminar series. I am Tex Kissoon. I'm president of the Global Sepsis Alliance, and I'm really honored to be chairing this important session. And I hope we have lively participation from the audience. This one is dealing with the issue of antimicrobial stewardship. And while AMR, you may have heard, is one of the major threats globally, it sort of relates both to sepsis and antimicrobial stewardship. And indeed, if we do not have antimicrobial stewardship globally, we are not going to be successful in containing antimicrobial resistance. So in this session, this exciting session, we have some very accomplished speakers who will be speaking to you on issues of strengthening policy globally, the issue of AMR in practice, the issue of low and middle income countries, the clinician's perspective, and the human cost of AMR, the most important issue. We should never forget about is the patients who are involved. Each of the speakers would have about 15 minutes to give their talk, and we'll have about 15 minutes at the end for a panel discussion. This seminar is sponsored by BioMeru with an unrestricted grant. BioMeru provides diagnostic solutions which determine the source of disease and contamination to improve health and ensure consumer safety. We are very grateful for this grant to support this program. And I look forward now to starting this such that we can hear these very important talks by our speakers. The first speaker is going to be Dr. Yvan Huttin, who is from the WHO headquarters in Switzerland. And he's going to be talking about from practice to policy, strengthening global responses to AMR. Thank you, Yvonne. It's now up to you. You're
Voila.
muted.
Yes. I was trying to control my unmute while sharing my screen, and I guess I've unlocked a new level of proficiency in PowerPoint on Zoom. Good afternoon, good morning, or good evening, colleague. It's really my honor and pleasure to share a few thoughts on stewardship and how the stewardship piece contributes to the work that's being done on sepsis. So thank you very much for that opportunity, and I hope that you hear me very well. I just have a small problem here. WHO headquarters, believe it or not, we've had a power cut. I'm running on the battery of my laptop. If by any chance I get disconnected, I will have to run on my cell phone and get back to you. Hopefully not. So there will be an incentive to delivering my talk on time. During this presentation, I will go first through some information on the global AMR response. Then second, I will go through the WHO stewardship guidance, and then finally close on some point on AWARE in action and its relevance to the work being done on sepsis. So in terms of the burden of AMR, which justifies our work, you can see here some of the key data. We always emphasize that AMR is both a current burden, but also a future threats. And you can see here the data also pointing at the increase in death from sepsis among those more than 5 years of age, that went from 8.8 million in 1990 to 11 million in 2019. And 8.51% of sepsis deaths are actually attributable to AMR. Now, also along with the burden in human health, we know that there's also an economic burden that's shown on the right-hand side of the slide, and also a risk for livelihood, as there could be up to 11% decline in livestock by 2050. In response to the threat of AMR, we have a global action plan. I'm sharing with you today the old one from 2015 that we're currently revamping with our colleagues from the Quadripartite Joint Secretariat. The 5 strategic objectives to tackle AMR include improve awareness of understanding, strengthen knowledge through surveillance and research, reduce incidence of infection, optimizing the use of antimicrobial medicine, and ensure sustainable investment. And for this, of course, an effective One Health approach is needed, because there's no point doing stewardship in the health sector if we're dumping antimicrobials in the agri-food sector, for example. So, of course, the remainder of my presentation will focus on the point number 4, which is the optimization on the use of antimicrobial resistance. Please forgive me for a bit of corporate talk right now. I just wanted to share with you that in the WHO, we work as per what we call our WHO strategic and operational priorities to address drug-resistant bacterial infection. I'm sharing with you because this has been endorsed at the highest level by our member state last year at the World Health Assembly. And according to that framework, which relates to the gap but is more specific to the health sector, we have 4 priorities. Number 1 is a prevention. Number 2, the universal access to diagnosis and treatment. Number 3 is a strategic information. Number 4, the governance, financing, advocacy, and etc. As you know, along with the World Health Assembly resolution last year, the work on AMR has been elevated at the highest multi-sectoral level in the context of United Nations General Assembly political declaration on AMR, which I have summarized on this slide. But most importantly, you can see that being squared at the bottom of the slide, you can see that one of the goals, and it's extremely important in the United Nations system, that we have a target saying that we should have at least 70% of human antibiotic use globally from the WHO access group. And I will go back to what is the global access, the access group. It's basically the go-to antibiotic, the one that are least likely to cause AMR. And why is it that we need stewardship? Well, one of the key reasons is that what's coming in the pipeline is not very promising. On the document that you can see here, we made an analysis of antimicrobial agent in clinical and preclinical development. And you can see on this graph on the right-hand side that we've sorted them according to whether they target critical, high and medium, and according to if you want the level of criticality. And when they're shown in dark blue, it means that we have something that's active. In blue, possibly active. In green, we don't know. And so you can see that the blue is not that common, and that despite the small increase in the number of agents active against critical priorities, the antibiotic pipeline is still insufficient to tackle drug-resistant infection. So if we want to have the antibiotics that we need for sepsis and other priorities, we must do more to preserve the effectiveness of the antibiotics that we currently have. So the WHO Aware system was put together to basically be the keystone of the system for global stewardship. It includes the Aware classification, the Aware antibiotic book. I was going to show you one to share with you that it's always at my reach, the Aware indicator and target, the implementation resources, and an important piece is to make it alive is a technical advisory group on Aware, but that we call the Tag Aware, and I will come back to this. This is the Aware classification in a nutshell. So we have the basis of the pyramid, the access antibiotic, the go-to antibiotic, those who are less likely to cause antimicrobial resistance. Then we have the watch one, which are more at risk of leading to antimicrobial resistance. And finally, the red one, the last resort, the one that remains active on the multi-drug resistant organisms, and that we should really keep for the indications when they are actually justified. What is not recommended is a fixed dose combinations of multiple broad spectrum antibiotics for which we have no evidence of effectiveness. So therefore, some antibiotics are actually not anywhere on this classification. So this was turned, as I mentioned to you, on this WHO Aware book, which is always also available on an app that is called Firstline, that would really encourage you to review. And the Aware book has been translated in a number of languages. And for every syndrome, there's basically a summary and explanation of what are the recommended antibiotics. I want to specify in the context of this Aware book that the WHO clinical management of sepsis guidelines are under development, and that the neonatal sepsis guidelines were updated in 2024. I mentioned to you that the Aware classification is also brought to life by this technical advisory group on AWARE, the TAG AWARE, that was established early in 2025. It provides technical advice to WHO to further develop and implement the AWARE system as a global stewardship tool. And you can find on this slide the link that describes the group, its members, and etc. And we went through all the processes to make sure that the recruitment, the selection of expert went through the right process. I want to also now mention that the Global Access Initiative is based on AWARE, because when we talk about stewardship, we want to make sure that everybody who needs an antibiotic gets the antibiotics, but that, of course, where you don't need an antibiotic, you should not get one. So this is stewardship is just as much as about access as it is about restricting use of antibiotics when those are not needed. So we engage in this project called Secure with our partner GARP, that includes a number of components, including engagements with countries and partners towards sustainable model. It includes looking at the estimated market and public health impact of access intervention. So let's not mix up access in terms of making sure we have access to antibiotics and, of course, the access antibiotics. These are two different things. Identifying the highest potential intervention based on antibiotic archetypes, reviewing the regulatory and policy initiatives to address shortages, developing an antibiotic forecasting model, the WHO operational guidance on antibiotic introduction that was published recently in September, and finally, a market intelligence platform and a supplier landscape. We have also, because AWARE is not only a classification, it's a system, we have a number of national regulatory initiatives that have actually been based on AWARE. And on this slide, you can see a number of examples from Nepal by which a number of antibiotics have been banned based on the AWARE classification, which is definitely the reflection that AWARE is not only a book, but it's also a broader system. So closing on this, and in lieu of a summary or conclusion, I thought it was relevant for this group to see how sepsis and AWARE and sepsis and stewardship, how the two can relate. So as closing comments, I would say that sepsis management and stewardship both aim to put evidence into practice to improve clinical outcomes. So while the sepsis is the apex of a pyramid of severity in terms of infectious syndromes, the principle that we need to work with in terms of stewardship remain the same. So we need to balance the prompt management of suspected sepsis and avoiding antimicrobial overuse, and we need to ensure that essential antimicrobials for sepsis are available when needed. We need to integrate the AWARE principles into sepsis guidelines, pathways, and bundles, such as, for instance, the optimal drug and dose, the de-escalation, and the duration. And we need to integrate sepsis management into stewardship policies and program as part of a broader quality of care. And finally, there need to be collaborations and knowledge sharing between critical care and infectious disease workforce. So altogether, in WHO, we like to think of sepsis, if you want, as the most salient and tragic manifestation of sepsis, but which is connected to a broader body of infectious, which is part of a broader body of infectious disease condition, and that the paying attention to sepsis needs to take care in a broader context of stewardship and infectious disease management. So these would be my concluding remarks. And I thank you very much, and I hope I kept the time. Thank you so much.
Thank you very much, Yvan. That was a brilliant conclusion, because one of the issues I see globally, many of my colleagues, both in critical care, infectious disease, and microbiology, seems to separate antimicrobial stewardship from sepsis. And it seems to me that it is unethical to talk about sepsis without talking about antimicrobial stewardship. They go hand in hand. One of the questions, and I know from experience in low and middle income countries, one of the problems have been also the issue of identification of organisms in their laboratories. And laboratory strengthening is one of the issues that needs to be done. I wonder if you can comment on how is WHO sort of encouraging countries to improve laboratory services?
In a very disciplined way, muted myself. So, of course, we do have strategic and operational priorities for the strengthening of laboratory services, and that's an important part of the AMR response. Now, in terms of sepsis, as most of the people on this webinar would know, the most clinical decision would have to be made before any laboratory results become available. So some of the stewardship principle in terms of the urgent clinical decisions must be framed on the base of experience that has been generated using strong laboratory services. But we need to be aware that in the emergency room, a lot of important clinical decisions for sepsis management will be done without the backup of a lab. I hope I answered your question.
No, thank you very much. I know, Yvan, you have to run to another meeting, and you would not be there for the panel discussion, but I'm very grateful for this wonderful presentation, starting this, so it will give us a lot of information, what is happening on a global level. And we look forward to calling you at other times with your expertise to really support some of our sepsis endeavors. So thank you very much.
Thank you so much. And of course, my slides can be shared. If they're put into a PDF, I'm very happy to share them with the participants of this webinar.
Wonderful. Thank you.
Thank you.
The next topic would be by Professor Alison Fox-Robichaud, a great friend of mine. She is a critical care physician in Canada here with me, and she'll be speaking about translating antimicrobial stewardship into clinical practice, lessons from the sepsis pathway. Alison, welcome. The floor is yours now.
Morning, Tex. It's a bit snowy in Eastern Canada, but we're having our first big blizzard, but welcome everybody. So thank you very much, Dr. Huttin, for setting the framework for how we practically put antimicrobial stewardship into practice. And I'm going to talk a little bit about some lessons from care pathways, and you may see some similar slides. So we're going to just review why antimicrobial stewardship and sepsis management are actually linked. I think we had a question related to that. Provide some strategies to include AMR stewardship into the care of sepsis patients particularly, and discuss how these might be achieved in your clinical setting. Perhaps some of that we'll get to in the discussion. So, this figure's been shown and probably will get shown again throughout the morning, but it really emphasizes the fact that AMR organisms are an important cause of sepsis and an important cause of sepsis-related mortality. And the prediction is, and Canada may look very rosy here, but the prediction is that this is going to get worse over the next 25 years. And unless we have some strategies to reduce it, it's going to be a bad problem. And the recent Global Burden of Disease report forecast, First of all, it reset the number of sepsis mortality, at least in 2021, to something that's astronomical, but we haven't seen the associated resistance with that. And I'm going to start by framing a historical context. And it is that antimicrobials are important, but not only treating for sepsis. This little figure in the upper corner here talks about the fact that really life expectancy definitely improved with two things before we actually had antibiotics. The first was early vaccinations, and the second was hygiene and clean water that occurred in the 1800s before we started to get vaccination. When I showed this recently to some students, they said, well, does that mean we're all going to live to 140 if we can fix all of that? So I'm not quite so sure. The second is a quote from Fleming in his Nobel lecture in 1945, where he actually predict two things. The first thing is it's not difficult to make microbes resistant to penicillin in the laboratory by exposing them to concentrations not sufficient to kill them. And the same thing can happen in the body. And then he could see this time where, because somebody didn't complete their course of antibiotics, or they gave their antibiotics to somebody else, they may actually contribute to resistance. And this, if you look at this timeline, Fleming gets the Nobel Prize with everybody else in terms of their work for antibiotics. And this is at the end of the Second World War. And within 3 years, they were already seeing penicillin-resistant Staph aureus, or Staphylococcus aureus. So, and then methicillin resistance came shortly after that. So I think that this concept that we need to think beyond antimicrobials for sepsis is important. The second thing I would say is prevention matters. And we really need to think about all of the strategies that we may do in our clinical settings or even at our home environments that may help prevent antimicrobial resistance and the spread of that. I don't know about your hospital, but my hospital reviews and reports hand hygiene rates. They break it down by the health professionals. And they try to do strategies that are going to improve the spread. And that includes infection control processes about, gloving and putting on protective equipment if you're in contact with an antimicrobial resistant person. But it also emphasizes the fact that hand hygiene is the best way. The other one that I haven't got is really thinking about how we monitor wastewater and other surfaces for the presence of antimicrobial resistance. But hand hygiene is one of those things. I'll give you an example. I walk into some areas of our hospital where hand hygiene might be the worst. And it's simply because they haven't provided the tools there and everybody reaches for the gloves and presumes that's going to protect them and everybody else. The second concept that's coming out is that certain antibiotics that we use for sepsis may in fact contribute to the antimicrobial resistance problem. And this is probably the most recent example, a bit of a natural experiment that occurred where in the setting of using anaerobic coverage for pneumonias where it may not be indicated, that in fact, the greater mortality associated with the use of anti-anaerobic coverage versus a lower mortality if it wasn't. And the conclusions in this paper were that in patients with anti-anaerobic coverage, administration, in this case of piperacillin and tazobactam, increased the duration. And the suspicion may be that by changing the gut microbiome, we actually add to the inability of our own natural microbiome to generate resistance gene or to generate appropriate antimicrobials. And I love this paper. It really talks about the overuse of empiric antibiotics for sepsis and presuming that everybody who comes from your emergency department door is going to have MRSA or Pseudomonas. When they actually looked at the prevalence of those organisms, Staph aureus was common, but MRSA maybe not so much. E. coli was common, but maybe not ESBL E. coli. And so in this sitting, we really have to think about those unnecessary empiric antibiotics that may be contributing to the resistance problem. This is a North America setting, but I suspect it's the same elsewhere in the world. This paper really focuses on the fact that does electronic surveillance for behaviors actually improve? And in this study, they actually set up a specific outcome to look at whether they were over-treating patients versus under-treating patients without an infection that was a true infection. So making the guess, does this patient have an infection? And then looking at their treatment. And when they over-treated versus those patients who were truly negative, there was longer time on antibiotics, there was a longer health stay in the hospital, there was increased mortality, and that may seem like a small difference, but and then there was increased C. diff infection. So both for the 3-hour bundle and for the 1 hour. So even those patients who are coming in septic shock, there may be some evidence that if you think about the right antibiotics for where you've got the infection and do all of those other protocols with an electronic surveillance tool, you may actually reduce important things that contribute to antimicrobial resistance. The next thing to think about that's coming down the pipeline is really how we dose antimicrobials in sepsis. Sepsis in itself may actually disrupt the normal pharmacology of antibiotics. So if we think of this complex interaction between the host, their immune system, and the drugs themselves and the bacteria, if you just use the example that resuscitation with sepsis increases the volume of distribution, increases edema, and the use of intravenous fluids may lead to, in fact, lower plasma concentrations and change the volume of distribution for those drugs. The use of membranes such as ECMO or renal replacement therapy may in fact bind or interfere with the clearance of those drugs. And then finally, organ dysfunction, either of the liver or the kidneys, can certainly change the clearance. And so people are now talking about making sure that we dose at maximal dose in sepsis, that we have tools for critically monitoring the minimally inhibiting concentration, and that we keep at an excessive level for those people with sepsis, and then really talking about the clearance for those drugs. So all of these dose interactions, I think this literature is building, and we may have some different strategies for people with sepsis compared to people who are not septic in terms of how we dose antimicrobials. What about de-escalation? So we have to remember that sepsis is the body's response to organ dysfunction. And while bacterial drugs, antifungal drugs, and maybe even to a certain extent antivirals are important for abating some of that and for pathogen killing, the ongoing response to the immunothrombosis from sepsis and the organ dysfunction may not require long periods of antibiotics. And I'll use the BALANCE trial as the first one. We now know that patients with gram-negative bacteremia, the length of antibiotics can be reduced from 7 to 14 days, from 14 days down to 7. So what about de-escalation from broad coverage? Do we, once we know what the organism is, de-escalate this? And this is from this table is from a large US study. So they actually looked at a number of de-escalation strategies compared to when it wasn't de-escalated or narrowed or actually stopped when they realized it was another cause of the organ dysfunction and not related to infection. And so while the actual incidence was low, they proved that it was actually safe, could reduce both mortality. So there's the de-escalation, the narrowing, and the cessation. So cessation, certainly in hospital mortality with de-escalation and narrowing was reduced. Intensive care unit admission was reduced with de-escalation and narrowing. And importantly and interestingly, de-escalation also reduced renal dysfunction and C. diff function. So it suggests that de-escalation or narrowing the spectrum of antibiotics, even when somebody's septic, and stopping in a timely manner is appropriate and safe and does not contribute to the ongoing organ dysfunction. So now let's move into some models of antimicrobial stewardship and where it might work. And I like this paper that surely just came out, BMC Infectious Diseases. I think I forgot to put the year, but it's this year, where they integrated, did the following things to improve their antimicrobial stewardship in the emergency department, which we often see as a very difficult environment. They integrated an early warning score into their triage, and they set thresholds for that early warning score so that they knew who was the sickest, where they might have to see them quickly, so that they got timely antimicrobials as appropriate. Importantly, and maybe not feasible in every setting, they had 24/7 access to an infectious disease consult service to really review their antimicrobial choices if there was any concern. They had ongoing and specific education to every member of the emergency department team, nursing, physicians as well. And they did a lot of organizational development in terms of looking at the current behaviors and what they might be able to change to make the process better. And throughout all of that, they used and measured the compliance with the guideline bundles through audit and feedback to the teams. And you can see that these are the odds ratios in terms of what they were able to improve, particularly their adherence to guidelines, the use of the bundle. Some of the other things in terms of timely administration and getting blood cultures and actually recognizing that the patient was septic maybe didn't make any shift in the adequate antibiotic therapy. And that comes back to this discussion about how difficult it is to actually know what the appropriate treatment was, and maybe this conversation about getting the right dose for these patients. What about when we move to the ICU? And I'm going to talk a little bit about what we normally do, but I love this from a recent textbook that was just published about the why, what, where, who, and how we do antimicrobial stewardship. And it really talks about these 5 Ds, the right drug, the correct dose, the right route, the duration, and the timely de-escalation, okay? And it says to focus on these things that we've talked about, thinking about the pharmacokinetics of the drugs, why we do it, who's involved in all of that, and studying that baseline data in terms of knowing what's happening. I will say in our unit particularly, we have antimicrobial stewardship rounds twice a week. The intensivist, the rest of the team, we don't necessarily have a microbiologist involved, but we do certainly have the infectious disease team, and we have both a infectious disease pharmacist and our own ICU pharmacist as part of that team. And we have a discussion of every single patient in the unit, making decisions about de-escalation or stopping if cultures are not going, or making decisions about whether the infectious disease team actually needs to come and do a formal consult for these patients. The paper on the other side is really the infographic from a single center study that was done in Korea, where they were looking in the surgical ICU, where you can imagine we spend a lot of time giving antibiotics. It was a before and after. They looked at the guidelines. They had the similar things, ID and a pharmacist rounding. They did it only monthly, and I would suggest that these more frequent meetings that we do in our unit actually helps, because we change critical care physicians every week, and to get consistency along that. They were able to demonstrate a reduction in anti-pseudo beta-lactam use. That was their primary outcome. They also reduced the use of Piptazo, or increased the use of Piptazo, but susceptibility to gram-negative, it was a secondary outcome. And they did have a reduction in mortality, which they hadn't anticipated as well. The last thing I would say, I work in an academic hospital, is there are some great strategies to make sure that all of the information that we're talking now is passed on to the next generation. And this is from the Health Services Delivery in the UK, talking about a bit of a systematic review they did, and these are their recommendations. We should be prescribing norms and checkpoints as an AMR and a priority in our hospitals. Consider reviewing when antibiotics may be not needed. I'm going to use the example of aspiration. I know a lot of trainees who, the minute they hear somebody aspirated, will jump on antibiotics, not waiting until they have evidence of organ dysfunction or evidence of actual infection. And what are we doing to train our learners about AMR? It may be that you need staff clearance to order certain antibiotics. In our hospital, you need infectious disease clearance to order certain antibiotics. And certainly engaging our learners, so our residents tend to join us when we do stewardship rounds, and certainly our critical care trainees often are the one who are leading with the infectious diseases team. And then this figure on the right really talks about how and models of engaging everyone from children to caregivers to society at large, in addition to the healthcare learners, about how we might do things. And I too will share these slides because I think there's some great tools and games that could be done with learners to talk about antimicrobial stewardship in all of these programs. I see we don't get to the parents. Maybe that's one of those important ones as well. And so in conclusion, I would say that antimicrobial resistance is a growing component of sepsis and sepsis mortality. It certainly is a multimodal approach to think about appropriate use of antibiotics, particularly when people are septic. And this includes all of the preventative strategies. It includes specifically integrating guidelines related to AMR and sepsis, and those action plans, they must be integrated, as must the entire team be engaged, including learners. And the assessment of stewardship programs, I really think, based on the WHO strategy, but really requires more evaluation in diverse clinical settings. Most of the literature is written in, I will say, in first world countries and not areas with limited resources. And with that, I'll thank you and hand it back to Tex.
No, thank you very much, Alison. I'm always amazed how you can condense and crystallize such a complex topic and present it in such a very coherent and cohesive manner. So thanks very much for that. I have many issues I can bring up, but I hope you stay for the panel discussion when we'll sort of talk more about it. So thanks again. And it is now my pleasure to introduce, as Alison said, the issues in low and middle income countries are so much different. And it's my pleasure to introduce my great friend from many decades, Mervyn, who is from the University of Wits in South Africa. And he's been a great friend of the Global Sepsis Alliance and a great friend for many of us for many decades, always inspirational. Mervyn, it's all yours.
Thank you so very much, Tex. A very gracious thank you to you and for the kind invite and for all the incredible work that everyone has shared today and that you're all doing, and to the GSA. It's an absolute honor to be here. We're going to chat today about aspects of sepsis, antimicrobial resistance, and antimicrobial stewardship. Very broad issue in resource-limited settings. I don't have any disclosures. And we're going to run through the three elements that have been alluded to and obviously focus on low resource settings. And we will use the term interchangeably, low middle income countries and resource limited settings, and then we will finally tie things up. So as has already been shared right at
Mervyn, are you sharing your screen?
I am.
Oh, we're not seeing any slides or anything.
Let me go back and recommence.
Wonderful. We're now seeing your screen, so it's good to see your face, but the added benefit of seeing your slides too is a bonus. Go ahead.
Thank you so very much, Tex. So as has been shared from the Global Burden of Sepsis study, we were told in 2020 that close to 50 million people per annum, in fact, develop sepsis, and sadly 11 million deaths ensue. More recently, in fact, shared earlier on this year, that number of deaths, in fact, based on the global agenda for sepsis, shared by the GSA, was deemed to be 13.66 million. And in fact, just about 2 weeks ago, a very excellent paper published in The Lancet suggests that that number now may be 21.4 million deaths, accounting for around about 30% of all deaths. The relevance of all of this is that this is data as we develop a greater understanding from a global basis, that we recognize more and more how relevant people who live in low and middle income countries are. Most sepsis studies have been entirely conducted in the developed world, exactly as Alison had shared. And if we look at excellent outcomes there, really only up to a third of patients really have access to excellent care. What's hugely relevant is to understand where most people in the world live and what the sepsis numbers in those areas are. And around about 85% of people live in low and middle income countries, and around about 85% of all sepsis occurs in low and middle income countries. The public awareness in these settings is extremely poor, the long-term sequelae frightening, and the short-term mortality is exceedingly high. And for those who have a major interest in the setting of younger children, 60 to 80% of all deaths from sepsis in children occur in low and middle income countries. And so this infographic shared by the GSA probably, which is a wonderful infographic, needs to probably be re-looked at. We're probably looking at one death every 1.4 seconds now. So far more than 1 in 5 deaths worldwide being associated with sepsis. And this major recognition of sepsis being a global health priority brought to the fore the WHO, which is the mouthpiece of the WHO, putting forward a resolution 8 years ago. And so we've gone almost a decade with the resolution suggested to adopt and adopted to improve the prevention, diagnosis, and management of sepsis. And we're sitting with a huge problem. So resolutions are great, but we need to implement issues. So we face massive challenges in low middle income countries, and just focus on the logistic challenges, the human resources, varying training, infrastructure, which can vary from the bottom picture here to my own hospital. That's what it looks like, in fact, this afternoon, with people crowding into the main corridor. Technology that's lacking, standards that vary, drugs and equipment that are often not available, essential elements like water and electricity, which are not available, support services that were touched on earlier, diagnostic laboratories, radiological laboratories, and local guidelines, all lacking. And this is compounded by delayed presentations. And so if we look at this graphic, which I adapted from Christina Rudd's critical care article a couple of years back, we start off with pre-morbid issues that are very difficult to control. Okay, very self-explanatory. If people do get sick, transportation's a major problem for them to actually get to a facility. If they do, and you're able to get to a primary care center, many of them are grossly underprepared and inadequately served to serve these patients. And if there's a referral that's necessary, the referral systems are often very, very weak, often no surgical capabilities, often no ICUs. And if people do survive and require some form of rehabilitation, that is lacking as well. And so it's important to understand as well the huge differential that there is between high-income countries, and you can see the numbers shared there of sepsis in high-income countries. But when we're looking at low-middle-income countries, more than 50% of all deaths are attributable to infections, with more than 90% of deaths globally from pneumonia, meningitis, and other infections occurring in low and middle income countries. And much higher mortalities. A recent paper from Tunisia in patients with septic shock revealed a mortality of 82%. I've just reviewed one from Kenya, very similar number, over 80%. And in countries like China, Colombia, and Brazil, in the region of 60%. It's important to recognize that the patient and pathogen profile of individuals is very, very different to those that one might find in high-income countries. And as a consequence, interventions management might require different elements. And this is a beautiful map sharing some of these, one of the papers that we put together some years ago with the Global Intensive Care Group, demonstrating differences: rabies, tuberculosis, tetanus versus conventional bacterial, fungal, seasonal, viral issues, for example, in Europe, North America. And frighteningly, even where critical care services may exist, this paper, I think, really is a startling issue commentary suggesting that even if you do get into a center where hopefully you might be seeking adequate care, it may be suboptimal. Critical illness in developing countries, about dying in the dark. So let's go back to some of the practicalities. When we're talking about sepsis, the integral components are being able to recognize the problem early, it's a medical emergency, and the three essential pillars that should be invoked in terms of management as a matter of urgency are early appropriate antimicrobial therapy, often a huge problem in low and middle income countries, restoration of adequate cellular perfusion. Sometimes the crystalloid that's available is normal saline, not the optimal balanced solution. Sometimes vasopressors are not available, and timely source control. And not infrequently, there's inadequate access to get adequate source control, surgery, percutaneous interventions, and so on. Relevant supportive care, sometimes entirely lacking. Ventilators, sometimes even oxygen may not be available. And post-sepsis care, hugely problematic. Very few countries where there's significant resource limitation have any form of rehabilitative care. And so if we go back to these major pillars, you can see where problems arise and why there often is such a high mortality in these countries. And these are the sort of things that we see every day. These are patients from my own unit, where adequate source control had to be done for necrotizing fasciitis on the left. A patient with cancrum oris, we had to remove half his face. Now, where do you go and find plastic surgeons to go and reconstruct the face? And so we had to call in a number of people, and eventually this patient did exceedingly well. Or a patient with meningococcemia, we had to remove both the lower and the upper limbs. An absolutely tragic scenario in this sort of setting, because there's no rehab to send the patient to, a young patient without limbs. So one of the major pillars that all of us have hung our hats on for many, many years is the Surviving Sepsis campaign. So initially the seed was planted in 2002, and from 2004, approximately every 4 years, new guidelines, including pediatric guidelines. And there's always been a major issue as to whether these are pertinent for low and middle income countries. And it's very, very relevant that over the years and following a lot of potential advocacy, that there's now greater inclusivity and lower resource settings are being addressed. And in fact, the upcoming Surviving Sepsis Campaign guideline will certainly be a lot more inclusive and very relevant. Further guidelines are available, specifically following advocacy in this sort of setting, and this was the first one close to 15 years ago, and subsequently there are 9 papers looking very relevantly at efficacy, safety, feasibility, and cost, covering a vast array of issues in a magnificent resource, and that's available in a book format as a free download. And when I looked about a week or 2 ago, there were 165,000 downloads of this. And more recently, there's been a global expert consensus statement looking at resource-limited settings and sepsis, another entity called the Sepsis Chain of Survival. And I was fortunate enough, together with some other workers, to put together a commentary utilizing the Wilfredo-Pareto principle. That is doing the most important 20% of issues to enhance around about 80% of outcomes, and this graphic shares the elements. What about antimicrobial resistance? And we know, and we can't get away from the fact that antimicrobials, in fact, in modern medicine are an absolute cornerstone. If we look at the number of lives saved, around about 200 million, but this issue of antimicrobial resistance becoming a massive problem, massive burden, shared by many, many authorities, and that's already been alluded to. But the highest impact of this problem is occurring in low and middle income class countries. In the regions of sub-Saharan Africa, Southeast Asia, dominantly Latin America, areas in the Caribbean, and these are the important pathogens that we are seeing. And in fact, Alison did allude to this, and for me, this was actually an excerpt from the actual Nobel Prize acceptance speech, and being warned that if we don't use antimicrobials correctly, we're going to run into trouble. I think everyone's familiar with this graphic, that the predicted antimicrobial resistance numbers will be 10 million deaths in 2050, and that may be many of our own lifetimes. And the cost there, astronomical, $1 trillion in additional healthcare cost. And if you put that into perspective, it's more than the number of deaths currently from malignancies all over the world. And I want you to focus on this. Look at where it's going to happen. It's going to happen in Asia. It's going to happen largely in Africa. And so we really have to look at things. What's driving it? Many of the issues are self-explanatory: inappropriate antimicrobial prescriptions, use of antimicrobials outside the health sector, such as in agriculture, and genetic factors, which we can't change really. And all of these are exacerbated by poverty and inequality. Consequently, low-middle income countries most affected. The inequities are huge. In fact, the remainder of this webinar could be addressed, but diagnostic access, antimicrobial access, affordability, vaccine inequities, and so on, all compounding the problem. And these are some of the specific drivers which have been essentially mentioned. I just want to focus as well on poor infection prevention and control, which is an easy issue to address. The impact is straightforward: massive morbidity and mortality. The economic impact I've addressed. And in fact, in the next few years, we're looking at $1 to $4 trillion US dollars in terms of GDP losses per year as a consequence. And once again, poorer countries most afflicted. This is the WHO global priority list of resistant bacteria. But I think this particular slide, which is the escape CCC, is something that all of us have to be aware of, irrespective of where we practice. And the additional Cs are Candida, the carbapenem-resistant Enterobacterales being a problem, and Clostridioides difficile. Don't forget fungi, very important. We're seeing changing epidemiology in low and middle income countries. In fact, much of the work that we know about Candida auris has come from low and middle income countries. In fact, we were amongst the first people to suggest how this should be most appropriately treated. Candida parapsilosis, now azole resistant in many low and middle income countries, and some of the guidelines, as I mentioned, emanating from these regions. Don't forget tuberculosis. Multi and extensively drug-resistant TB, massive problems, 500,000 patients globally, most in low and middle income countries. Resistance to artemether compounds and artemisium compounds from Southeast Asia being reported, emerging resistant to wonderful antiretrovirals, including the new integrase inhibitors, and oseltamivir being a problem also with resistance with respect to influenza. Neglect to tropical diseases. People don't look at these things, but we see them. Leprosy, resistance to the drugs that are shared here. African trypanosomiasis. In my unit, we in fact admit every now and again a patient, and we're seeing resistance to malastoprol. And leishmaniasis, similarly resistant, and we are seeing resistance in animals to antihelminthics, and it's just a short journey before that becomes an issue in humans. The multi-pre-extensively and extensively drug-resistant TB, these are in fact the definitions. But there's been a massive breakthrough, and it's come from low and middle income countries. From a condition that could take 24 months to treat with high morbidities and mortalities, we can now treat people with a 6-month oral regimen based on some fabulous work that has come from low and middle income countries. And if you look at this graphic, it puts it into perspective. A couple of tablets now for 6 months, and we can change outcome, morbidity, and mortality. What about healthcare-associated infections? And I just want to share some really important data recently published. If you land up in a healthcare facility, you've got about a 1 in 4 chance of developing a healthcare-associated infection if you're from a low-middle income country. And low-income countries have the highest prevalence, almost 40%. Just to exemplify that, if you've got a device in a patient in a low-middle income country, 5-fold higher rate of device-associated nosocomial infection and more likely to be resistant. This is the reality of what we see. This is what we're talking about. Necrotizing fasciitis in a patient with a peripheral line-in not adequately sterilely placed. And this patient, we had to remove the limb. She was the breadwinner. And in low and middle income countries, there often is no further rehabilitation. It was an awful scenario. So what can we do? What simple things can we do to limit, and if I can use the term, escape these problematic pathogens and tight infection prevention control? I'm going to just share some pictures from my own unit. Before you enter the cubicalized unit, you have to wash your hands. Before you touch the patient, same story. We put on a plastic apron. They're dedicated stethoscopes and equipment, and we do use, after washing hands, disposable cheap gloves. And in fact, the aprons I've costed are less than 1 cent in terms of North American figures or European figures. And then when we finished, we dispose of those, wash our hands again, exit, and then rewash. And in fact, this is a picture of my own unit, which looks spotless. We also have UV light in because of tuberculosis. And we limit our infections to pretty much zero. Over the years, I've been asked, how can we integrate these issues in a simple fashion? And so I was fascinated. Alison shared the 5 Ds. Over the last 15 years, I've tried to put together about 25 of them. And here they are. And in my mind, this one slide encompasses everything that this webinar is about. The first is deciding whether a patient needs an antimicrobial or not, knowing details of the drug and the bug. I prefer to call the thug, and the mug is the host. And we can go down all of these. She touched on the differences in the critically ill to reevaluating on a daily basis all the damage that she spoke about, collateral damage from agents, which we need to be aware of. And the problems that we're seeing, I don't like to call developing problems, I like to call them delinquents. And she spoke about the differences in the critically ill patient. But if we can optimize PK/PD elements, we can kill the bugs, and dead bugs don't mutate, and it doesn't matter where we work. Duration's really important, and I thought just for people from a pragmatic perspective, there might be some important guidance here based on all the literature that's out there. For CAP, 5 days more or less is adequate, 72 hours following cessation of the constitutional features. Happen that around about 7 to 8 days, unless it's if you have a lab that can give you access, and it's a non-lactose fermenter, 10 days, bloodstream infections, 5 to 7 days, intra-abdominal infections, source control, and then only 4 to 8 days, and urinary tract infections, 3 to 7, even if they're complicated. And that's it in words. So finishing off, what are some of my personal insights in the approach? I think it doesn't matter where we practice. We're in such a privileged profession. If we have challenges, they present opportunity and we need to overcome them. And that's what we ought to do. One of the terms that I coined a while back is being poor doesn't mean poor care. In fact, excellent care is possible, feasible, and doable. And we're often told just do more with less. And I say that is fine, provided we don't do less for more. So never fall into that trap. And it's the simple things that make a difference, as we've shown. Tight infection prevention control, good use of the antimicrobials, the Ds, together with clinical acumen. And people bandy around the term, it's impossible, you're never going to change things. Others say that nothing is impossible. I like to turn the whole thing around. Impossible is nothing, provided you have focus. And if you do, you can achieve things. These are some of the interventions and advances we've introduced in South Africa, which were alluded to, including veterinary issues. And so as the sun sets on this particular talk, and this is a Southern African sunset of recent things, I think the conclusions are self-explanatory. And I think despite the massive challenges and the huge logistical infrastructure of problems and the plethora of infectious diseases, sepsis and antimicrobial resistance, and all the differences and inequities, in fact, we can move forward. We need inspired leadership. We need to strive for excellence, and we definitely can do it. And I'm going to finish off with a low middle income individual that did change the world. In fact, it was an inspiration to me and someone I resonated with very, very deeply, very wise. And he had the following to say: "It's in your hands to make a difference." And the quotation ends, "to make this world a better place for all who live in it." And it's feasible. So lastly, as I always do, I want to finish off with a couple of seconds of music. Listen to the words. It indeed is, and everyone in this world deserves a chance. And a very gracious thank you, and thank you for the kind invitation.
Thank you very much, Mervyn. I've known you for many decades, and there are two words that I always describe you: an eternal optimist. And I think that is what it takes to work in the environments that you describe. And I really appreciate all you're doing, and I hope you stay for the panel discussion. So very much appreciated. The next talk would be given by the perspective of a frontline physician by Syed. who is from the United States. She's an infectious disease specialist, so it would be, I look forward to hearing her perspective on the AMR issue and antimicrobial stewardship. Uzma, it's all yours.
Thank you so much. Let me go ahead and share my screen here. Thank you so much for this wonderful event and fantastic day so far. Today, I'm going to be sharing some clinical perspectives from the front lines, rapid action along with responsible use. Very, very important as we talk about AMR and sepsis and how closely they are both interrelated. Let's dive right into it. So real world scenarios, we know that time is everything, and we know that sepsis kills quickly. So there is definitely an urgency in treatment. AMR, we know, hinders the sepsis treatment. So what is really important in this? We need precise stewardship to save lives, not necessarily to hinder our treatment. So why does stewardship really matter in sepsis? Well, we know that resistant pathogens increase mortality, and we know that de-escalation of antimicrobials leads to improved long-term outcomes. We're not talking about making things more difficult. We're looking at making things better for our patients. We know that this leads to decreased rates of AMR, and we know that patients have better outcomes. We know that overuse of antimicrobials can lead to significant impact on patients, whether it's leading to kidney failure, liver failure, intolerances, a lot of GI side effects, increasing rates of C. diff. We know that there's profound impact from overuse and misuse of antimicrobials, drug rashes, neurotoxicities, you name it. Patients can present with different symptoms and syndromes. So we have to be really careful to make sure that we're using appropriate antimicrobials. We also should focus on the fact that de-escalations of antimicrobials does not lead to increased risk. Now, this is very much based on evidence, and we know that our goal should be really to have pathogen-directed treatment. So stewardship, in turn, protects our patients, and it's not just protecting the antibiotics, but we want to look at the patient as a whole. What sepsis and AMR looks like. Here, I want to share a few examples of patients that I may see on any given day. Now, being an infectious diseases physician, I see septic patients every day. I see patients with antimicrobial resistant infections every day, and I see patients that have both. And unfortunately, this is very much a reality in my world. And it's very, very difficult for the patients that I treat, and it becomes very grim prognosis a lot of times when my patients end up from the emergency room. They end up from my hospital, from my office setting to the emergency room, to the intensive care unit, and oftentimes they don't do well and they have very poor outcomes. So let's look at a couple of scenarios. We might have a 40-year-old patient who arrives to the emergency room with a fever, elevated heart rate, low blood pressure, and she's very lethargic despite seeking medical care. So a week prior, she was having some urinary symptoms. She went to an urgent care. She was prescribed some antibiotics. She continue to deteriorate. And so what happens? She ends up to the ER. Why does this happen? Well, she's developing sepsis from a resistant urinary tract infection. Unfortunately, this scenario is very, very common. 20, 30 years ago, we weren't in the situation where we are now, where many patients come to our emergency rooms with resistant urinary tract infections. A lot of them present to the outpatient setting, but unfortunately, they are not having access to specialized clinicians who can recognize that they may be at risk of having that resistant urinary tract infection from resistant bacteria and need to then treat them with appropriate antimicrobials. So this patient in this scenario has a bacteria that's resistant, ESBL, whether it be E. coli, Klebsiella, any of the gram-negative infections. This is a very common scenario, and timing is everything with sepsis, as we mentioned before. If these patients don't show up to the ER when they do to really get the appropriate antimicrobials, they can have really bad outcomes from this. And we're talking about young, healthy patients that can present like this. Let's look at the next patient. We know that COVID-19 impacted the whole world significantly, but there was significant viral sepsis from COVID-19, and this really went on undiagnosed and undertreated. So we can see when our patients come in septic shock from viral infections, they can be admitted to the ICU, they can be on a ventilator, they have respiratory failure, and now they develop more consequences and more unfortunate, worse outcomes because they develop secondary bacterial infections. And then what happens? You're trying to care for this patient now. Their viral infection is being treated, and you're trying to give them adequate care, but now they have secondary bacterial infections, and all of the antibiotics that you're prescribing for them are not working. The patients continue to deteriorate. Well, they have further increased resistant bacteria, and they're now dealing with a respiratory infection, a bacterial infection, and pneumonia from something called CRE, where now the bacteria has become resistant to the carbapenems that we frequently use to treat these complicated infections. Let's move on now to a patient that's coming from a nursing home. You have an elderly patient who's got underlying medical conditions, and this patient is colonized with different types of bacteria. Well, what happens? You diagnose a bacterial infection in this patient that's in the bloodstream, but you can't eradicate that infection. They keep getting this bacteria back in their bloodstream, and they are very, very sick. They're first in the medical ward, then they're admitted to the intensive care unit. They require medications to help sustain their blood pressure. They're just getting worse. And no matter all the strong antibiotics that you're giving them, they're not able to clear this infection because of their history of being colonized with this multi-drug resistant Pseudomonas. This is unfortunately a reality that's becoming more and more common. Then let's look at another young patient, a 30-year-old female who presents to the hospital, and she has a delivery, and now she's developing complications. Well, what does she have? She has postpartum endometritis, and she's having recurring and persisting fevers. Why is this happening? Because, the primary team that's caring for her is prescribing appropriate antimicrobials, but they don't realize that she has a resistant bacterial infection now. So they need to broaden her antibiotic therapy to really give her good outcome and better care. Then we have a 65-year-old patient that develops a methicillin-resistant Staph aureus bloodstream infection. And this unfortunately seeds, to the heart. He then develops endocarditis from this. And this is a fairly common scenario that we have where patients come in with these resistant bacterial infections, and they can be very, very critically ill. And they have different focuses now, different nidus of infection where the bacteria latches on to different areas, and it becomes very difficult to eradicate these infections. And then finally, we look at a 55-year-old that comes in with prostatitis. And now this prostate infection has developed into an abscess. And unfortunately, the regular run-of-the-mill antibiotics that we'd use to treat these infections are not helping get this patient better. Why is that? Because he's got an infection with a resistant bacteria, something commonly we see with a vancomycin-resistant enterococcus. Well, this becomes very difficult to treat, and the general practitioner, regular clinician, has a lot of limitations in their knowledge and their ability to treat these infections and eradicate them. And that's why most of the time I'm called in as an infectious disease physician to really help care for these patients. But this scenario, which used to be far more rare many decades ago, has become, unfortunately, more and more the norm these days. Well, what happens when we see AMR interfering with sepsis management? We say that there's a delay in therapy. We see that these infections are very, very difficult to treat. Why is this happening? Well, we know that resistant infections give you longer infectious syndromes, right? People stay infectious for longer, and it's difficult for them to eradicate these infections. This leads to worse outcomes for our patients. What do we see in these scenarios? Prolonged bacteremia. That bacteria in the blood just keeps staying there. We can't eradicate it. Patients present with sepsis, septic shock. They're in the ICU. And all of this leads to increasing mortality. We see this often in clinical scenario. We see this as the loss of the golden hour. We watch our patients deteriorate in front of our eyes. It is really heart-wrenching to see this happen. They have these persistent resistant infections, and all of a sudden they have hemodynamic compromise. This leads to multi-organ failure. It's a very common scenario in the ICU for many ages. It used to be the case that these are just the extremes of ages, the really young, the really old, and they have all these risk factors. Well, that's no longer the case. We're seeing young, healthy people coming in like this. And unfortunately, we're dealing with the acute critical illness for the patient, but there's a lot of long-term consequences that we also have to think about. If we can heal them and get them out of this critical phase, out of their sepsis, out of their septic shock, we still have to to worry about the downstream effects of this when they are recovering in the hospital, in a rehab facility, when they get home. What are all the consequences of this sepsis, of this multi-drug resistant infection that is going to be with them for the rest of their lives? Are they now going to be on dialysis for the rest of their lives because of the kidney failure that they developed? Are they going to be trach dependent because of the respiratory failure that they developed? There's so many things. And let's not forget about the mental health issues and the anguish and the post-sepsis syndrome and trauma that they develop from being in the hospital. These are all things that our patients deal with on a daily basis. We know that we're left with limited empiric choices. There's this moment when no empiric regimen feels so inadequate. We talked about all these growing resistant infections. We used to use ceftriaxone, a commonly prescribed antibiotic, and this is no longer sufficient. We know that there's a lot of use of piperacillin tazobactam. That used to be a broad spectrum antibiotic for us. And unfortunately, in many scenarios, this is no longer reliable. We see that we have increasing resistance to carbapenem antibiotics, and this was our broad spectrum last line drug for many, many years. And unfortunately, now we have resistance to this antibiotic as well. And we know that rates of MRSA vary drastically throughout different regions, different communities. So we have to think about all of these things. Basically, what we have to look at is that empiric therapy has become a balancing act, one between adequacy and overexposure. And what happens when we're in this really difficult scenario? We find ourselves using last line drugs because we don't have that great pipeline of antibiotics that's coming to really heal our patients, to cure them, to save their lives. And the antibiotics that we now, and the antimicrobials, even antifungals, antibiotics that we have to use now have a really horrible side effect profile. Even antivirals that we have are not really well tolerated for some of our sick patients. So we have to manage these septic patients with these resistant infections, and this means using some drugs that are off-label. They haven't been studied. They haven't been studied for these specific infectious syndromes, but we have nothing else left to offer our patients, and we have to hope that this regimen will work and help cure their infection. We have to use certain combinations. Again, we don't know what the synergy is going to be like. We don't know if these are going to have increasing side effects on our patients. And again, as I mentioned, we have to use drugs that have less favorable side effect profiles. So we have a lot of intolerances. We're trying to eradicate one problem and cure this patient from their infection, but we're in turn creating so many other downstream consequences of that may be short-term and even long-term. So as a clinician, you have to weigh the side effects against survival. And in real time, this is often done with a very little margin for error. We find ourselves in diagnostic uncertainty all the time. We know that AMR complicates diagnostic interpretation. We have to think a lot of times in the middle of our day, was this decompensation for this patient due to the resistance of this bacterial infection, or was it in fact the progression of the sepsis? Is the organism that we're dealing with a colonizer, or is this actually the culprit? Is this the thing that's causing this scenario in our patient? Are we missing fungal sources because of the antibiotic pressure that we're putting the patient to? This uncertainty leads to escalation, and sometimes it doesn't lead to precision, and that's what we really have to focus on. Source control is very problematic for our patients, especially our septic patients, especially our patients that are septic because of antimicrobial resistant pathogens. A lot of our patients will have drains. They've had surgery, they have drains in place, whether it's postoperatively, whether it's after having a IR-guided procedure to drain an abscess from an appendix that ruptured or any other type of complication that they've had. These drains can get colonized. There's more complications that can develop from these being in there. Hardware becomes colonized. We have more and more patients that are increasing, having longer life expectancies. We have patients with pacemakers, defibrillators, prosthetic joints, you name it. And oftentimes, if there's bacterial infection, if people are predisposed to sepsis or AMR, the bacteria, then colonizes this hardware, and it becomes very difficult to eradicate these infections. We know that we talk about biofilms a lot on invasive lines that are there in prosthetics. So our patients that are very, very sick in the ICU, they have many central lines in place. And unfortunately, these can get secondarily infected, and that becomes very difficult to treat and to eradicate that infection. Recurring infection is very, very common for our patients. And unfortunately, AMR transforms what should be routine management into very complex multi-day decision-making facility for us as infectious disease physicians. This is what we do on a daily basis. We know that AMR and sepsis is this vicious cycle that we see. Resistant infections make sepsis more severe. We see this in our patients. When patients are having severe sepsis and septic shock, we have to use more broad-spectrum antimicrobial therapy. Unfortunately, sometimes more broad-spectrum therapy leads to more resistance. So without stewardship in place, this cycle just tightens and get worse and worse. That's why it's really, really important that we embed good antimicrobial stewardship into sepsis care from the beginning. So our real patients often struggle because of AMR. We know that they have longer ICU stays. We know that they have recurrent hospitalizations. We know that there's delays in their discharges because of really complex antimicrobials that we have to use. We have to find therapies that we can continue to give them sometimes when they need to leave the hospital, where they have, prolonged bacterial infections, endocarditis, bone and joint infections, spinal infections, epidural abscesses. All of these require a long course of antibiotics. And when you're dealing with a resistant bacteria, then you have to use antimicrobials that are very expensive, that are difficult to coordinate for them to leave the hospital. And sometimes they end up staying in the hospital even longer because of that. And then what happens? They're susceptible to other types of infections just from having that acute care facility stay, where they're getting more and more complications from them being there. What about the emotional toll on the patient? We haven't even talked about that. What happens to that patient when their provider comes in and their physician comes in and tells them that your infection is resistant to all the therapy? It's resistant to the first line therapy. We're going to try the second line. We're going to try the third line. But what impact does this actually have on the patient? Well, I can tell you as a frontline physician that this is tremendous. There is so much emotional toll on a patient. They're already physically going through so much, being hospitalized with this acute illness, and now they have to hear things that are very traumatizing and debilitating for our patients. So as frontline clinicians, we often feel responsible, even though AMR is a system-wide problem. Importance in AMR and sepsis management is early recognition as well as targeted empiric therapy. We have to remember that de-escalation is very, very important at 48 to 72 hours when we have our diagnostic modalities to aid in that. So when the cultures come back, when we have more imaging technology available to really hone in on what is the actual infection and what is the pathogen that's causing it, we have to focus on de-escalation. Duration stewardship is very, very important as well. And this was alluded to before, that oftentimes prior thought was that a longer duration of treatment is going to help this really serious infection, but that's not the case. We know that shorter is often better. And using those diagnostic stewardship tools is really going to help us for our patients. So it's really important that we integrate sepsis protocols into national and local AMR action plans. We need to standardize early warning and data-driven reporting systems to really help our patients. Use that technology, leverage AI to really help with our patients with sepsis and AMR. And we need to really expand equitable access to quality-assured antimicrobials, as well as diagnostics and vaccinations. Our goal should be not just on treatment, but on prevention. That is so, so important when we work on education of the public, providing the resources, reaching people where they are, making sure that they have equitable access, not just to therapeutics, but to also to preventable measures such as immunizations, which is very, very important to prevent infections. So finally, important takeaways are that stewardship in sepsis saves lives by improving accuracy. AMR complicates everything from diagnosis to empiric therapy to source control. Frontline clinicians are usually the first and oftentimes the best stewards, and every decision from culture to duration really shapes the future of AMR trends. Stewardship is not just about restriction, it's about responsible, life-saving precision. So in conclusion, I just want to say that we cannot win the fight against sepsis if we lose the antibiotics to resistance. Thank you so much. I'll turn it over to you, Tex.
Thank you very much, Uzma. And I think if we weren't taking this seriously before, this is a wake-up call. And you raise a point that is very important. What is the effect of all this on the patient? So I hope you stay for the panel discussion. But I think for me, we have one of the very important talks coming up right now. This is the human cost of delayed diagnosis and resistant infection. And we invite now Carolyn Mtambalika from the UK to tell us her experience.
Hi everyone, my name is Caroline. Thank you for having me today. and I'm just going to share about my personal experience with sepsis as a patient. So my sepsis story starts with a stage 4 cancer diagnosis in May of 2024. I was diagnosed with stage 4 Hodgkin lymphoma and started chemotherapy early July. Now, following the first week of chemo, I became really unwell. I had sickness and vomiting, and we ended up calling an ambulance the following Friday. I'd experienced falls, weakness, fatigue. I had issues with my mobility at that point. And what we didn't know then was that the chemo was so strong that it had left my immune system entirely compromised. Somehow I'd caught a stomach bug infection, which was causing the vomiting and nausea. And that's what started my sepsis journey. So the early Saturday morning, we called an ambulance and were rushed to the hospital. I was admitted and they started antibiotic treatment immediately. So they knew to start the sepsis protocol because obviously they knew of my condition and the fact that I was on chemo. And over the weekend, I had started to improve, but by Monday morning, I suddenly deteriorated again. I collapsed on returning from the bathroom. I was unresponsive. Fortunately for me, my mom was around, so she was able to call for help, and we got assistance pretty quickly. But I don't remember anything from coming back from the bathroom to waking up. I don't remember how I got back in the bed, but I woke up and they've connected me to oxygen. They've got lines in my arms. There's pumping fluids and everything going on. They've connected me to a blood pressure cuff. And at that point, I think my blood pressure was something like 42, which is quite severe. So my vitals are all over the place. My heart rate has shot right up, it's skyrocketed, and my temperature was really high also. They put a catheter in and then they told me that it was neutropenic sepsis, which I didn't fully understand at the time, but now I guess I understand that it's caused by poor immunity. So because I was immunocompromised, that's how I then ended up having sepsis. So I spent 5 days in ICU, monitoring on and off. There were all sorts of things going on with my bodily function just wasn't normal. I needed all care. And going from being a healthy 29-year-old with my own strength, I was exercising regularly, I was living a normalish life as you can have at that time, to being in ICU and needing all care and support was quite traumatizing, to be honest. But thankfully, after the 5 days, I was transferred back to the ward for the rest of my recovery. I received treatment there. And I had to have several pints of blood because I then became anemic and so on. And when I came out of the hospital, I eventually continued with my treatment on the chemotherapy and ended up finishing in December on that. But although I've recovered from the chemo, a year on, I'm still dealing with the after effects of sepsis. So I still have some issues with mobility. I still have some fatigue, some cognitive impact, but memory loss. And I think for me, the worst thing has been the psychological impact of it. So dealing with the fear of recurring infection and dealing with the trauma of everything that's happened has been the biggest thing for me. I am back on my feet now to a certain extent, not as I was before having sepsis or before my cancer diagnosis, but I'm definitely doing much better. But it's also knowing that I don't know if I'll ever return to that. So thankfully for me, they treated sepsis quite quickly, and that minimized, I guess, the impact of it on my day-to-day life. But knowing that there are still some impacts that I'm dealing with now, I always wonder whether or not there was more that could have been done or what should have been done. And as I'm not a medical professional, I don't really know what maybe could have been missed or what could have been done differently. So I think that's just a quick rundown of my personal experience, and thank you for listening.
Thank you very much, Caroline, for that sort of moving story. And I can't imagine what you've gone through, but I'm glad you're here still with us. And I look forward now to the panel discussion. I know we're behind time, but this has been a very, very informative and fruitful sort of set of information we've gotten from our panel members. So you only got a few minutes again, but I'd like to just raise a few questions to the panel. One of the questions for Alison is the issue, Alison. You may have heard you were at the World Congress of Intensive Care in Vancouver when it was raised that one of the most important source of resistant bugs and infections in the ICU are the hospital sinks.
Mhm.
And the question is, how do we deal with that? Because we've always spoken about the issue of hand hygiene, having the sinks, et cetera, and now we hear this is the source of so many of the issues. And I know some have said about what we put down the sink, et cetera, but I'm thinking, what are your thoughts of that?
So I'll start with a story, Tex. Once upon a time, probably about 15 years ago, we had a multi-resistant Pseudomonas in the traps of every one of our sinks in the ICU. We had to replace every single trap in that sink. As a result, we changed our cleaning protocol. We've now forbidden fans. I'm thinking, Mervyn, air conditioning is important, but we've now forbidden fans for spreading things. We've had Acinetobacter subsequent to that in the unit, again, spread by people having fans at the bedside. I think there's two things, Tex, and I really value Uzma's opinion as well. There is the technology available to screen trap water coming out of a hospital system to look for AMR bacteria coming out into the water system to track it as it's coming. But should that technology be used on a regular basis? Should we be screening for the water coming out of our hospital that gets into the water system? We presume it's going to get cleaned in most of the first world, but we can't guarantee that. So yes, I think sinks are an important source, and regular cleaning of the unit too, not just when we have a patient in contact precautions or whatever where we get a full clean, but that sink is sterilized on a regular basis. So there's my story. Do I think it's important? Absolutely. Do I think we have some strategies? Yes.
Thanks very much, Alison. I know you have to go in a few minutes, so while you're still here, I'll give Mervyn a chance to respond.
Thank you so much, Tex, and thanks so much, Alison. The sinks are an absolute issue, including in low resource settings. One of the huge problems, even if you try and clean them adequately, is that the sinks in the plumbing system is all integrated and there's extensive piping. So cleaning the surface of the sink often does not address the problem. And there's also biofilm that sticks to all the piping way and beyond. So we need to sit down and think how we ought to best address this and look at the piping issues. You're quite right, fans are an entity. We're very fortunate in Africa, as opposed to, I'd heard you mention the blizzard earlier on, that's there. We don't. We open the windows. We open the windows. It gives you better air exchanges than any negative pressure facility or any extractor fan. And, it's you don't need conventional bedside fans for that particular purpose. In fact, you get 6 to 12 air exchanges, which is better than any system. But depends on where one actually is. So I think these are all very important issues. We also have ablution facilities often nearby. And in fact, it's been shown that flushing the ablution facility, you get droplet spread in quite a vast area. And so we really need to rethink how we environmentally construct our units go back and have a good think about these things. Very, very important point. And thank you for bringing it up, Tex, and for your wisdom, Alison.
Thanks very much. So I want to turn to Uzma now. Uzma, in your presentation, you painted quite a dismal picture of what the scenario can be and what it ends up. Yet the thing that I took from it that we need to really emphasize more is stewardship protects patients. Can you elaborate on that a little more? Because I think the message that most people get antimicrobial stewardship, or we are sort of protecting, preserving antibiotics only, but the patient, who is the central and the most important person in all this, does not come to the fore. So can you amplify that message a bit?
Absolutely. I mean, I think that's exactly the point that I wanted to share, is that our focus has to be patient-centered. I mean, that's who we're everything for. You know, our goal in a day-to-day is to save lives and to provide better care for all of the world's citizens, right? And every area. And I think this whole narrative on AMR and sepsis, oftentimes it is a little alarming because we want to ring, but sometimes the patient-centered focus of that kind of gets diminished because everybody's just harping on, you know, the sound bites of AMR and the growing problem. And it is talk about how we can, you know, tailor that stewardship to focus on the outcomes for the, you know, it's all very much intertwined. And so all these interventions, the preventative measures in place to really capture the patients from the beginning, to have this health journey for them where we're optimizing their health care, where we're preventing and minimizing their risk growing antimicrobial resistance, which then leads to worse sepsis and outcomes for them. So, you know, making it patient-centered and making the focus of stewardship patient should be the front and center, you know, whether when we're doing our rounds in the ICU with our clinical pharmacists on stewardship, or educating our providers, whether it be students, the aides, you know, the physicians, everyone from the hospital administration. Everything needs to come back to the patient. You know, that is really the focus on all of this. And sometimes can get lost. So if we just embed that stewardship from the beginning to really highlight stewardship is going to improve patient outcomes and make the patient the center of this. It's going to AMR outcomes and their sepsis outcomes. And we can show that, you know, when we do when we do rapid initiation of antimicrobials, adequate de-escalation in a timely and shorter durations, and we can show that the patient's getting better. We follow them out of the hospital, the healthcare setting, and we have that outpatient follow-up, and we see that we're having more impact and better outcomes for our patients. I think that the patient has to be the center of this always.
No, thanks very much. Alison, I see you have your hand raised, but I'd like to Caroline first. Caroline, as a patient, were you aware of antimicrobial stewardship or resistant issues before you went to the hospital? And you've heard these lectures. What would your approach be when you're going next time?
So it's not something I was aware of prior to my experience. And honest with you, I'm not entirely sure whether that was the case for me. But I think it's something that I've done with knowing, which would have helped to make sense of a lot of the things that were happening, because going into and immediately being put on antibiotics, I don't know why are they doing that? And I think my condition, it was difficult also to explain to me. But I think it won't happen again. Should it happen again, I think I'll be better informed this time around and be able to do things a bit differently, maybe.
Sure. I think it's difficult to advocate for yourself when your blood pressure is about 42.
Definitely.
I think that's one of the things we have to think about, is that we talk about patient advocacy. When they're compromised, it's a difficult issue. Alison?
Yeah, I'm going to sign off shortly, Carolyn. Thank you for your story. It just emphasizes that we also need to do a lot for our people who are recovering from sepsis as well. My question really was this issue of the interact preventative strategies and thinking about automating. You know, I spend a hospital doing QI work, and what can I automate in the system to make people aware. Alarm fatigue. Alarm fatigue, as we know, in the hospital is a huge issue. So if you set up all of that long list of your D strategies, what would be the 3 or 4 that really have had the biggest impact? About, you know, the TB issues in South Africa, and what has been the biggest impact out of all of those Ds?
Thanks very much, Alice. I probably would put it into a single term. Choose the simple element. If you do the simple things well, in whatever aspect, including this, you're likely to have favorable outcomes. So the duration, making the initial appropriate selection, the decontamination washing that you so eloquently alluded to. In fact, that was discussed in the 1880s by William Osler. In fact, if I'm not mistaken, he said something like, water and common sense are the best disinfectants. And 140 down the line, that still remains the issue. And, you know, I like wordplay, and many years ago, I also developed a thing called the P's. The essentially are the following: always stick to the principles. That's what we discussed and shared today, are important principles. When you deviate from principles, you run into the second P is be patient. And we all want instant results. We started the antibiotic, the patient's not getting better. Why is the patient not getting better? If you've chosen the correct antibiotic based on good clinical acumen and other adjuncts, if you're patient, you're likely to move along in the correct direction. The next P is practice, and that means experience. This is hugely relevant. And the fourth P is what all of us have demonstrated here today. Good friend Tex and I have had many discussions over many years about, and that is passion. Don't lose your passion for the patient. And if you have those P's, you're likely to proceed on the right path. So all of the D's have a role, but perhaps one final is to consider every single day, the daily reevaluation, and Uzma, you would recognize it as well, the ongoing need for antimicrobials, if they have begun. And so it comes back to the simplicity issues. Great question, and thank you.
Well, thanks very much, Mervyn. I have one question for you, and then we'll have to end this. We can go on for hours with this. The issue mentioned about, or rightly so, is that only 10 to 30% of individuals have access to excellent care. So 7% is suboptimal care. And then you mentioned mortality from to 80% in different countries. And, you know, I've been to several times in the last month talking about research, what research we need, et cetera, et cetera. And it seems that we don't need a new molecule right now. We don't need more randomized tests of one type of fluid versus another. We know what. And I remember the Lancet Commission quite a couple of decades ago that for the poorest of the poor, we need the science of delivery, implementation science. What is your opinion? What should be done in these countries that has these dismal sort of outcomes?
I absolutely concur with you. We've spoken about infrastructure and logistics. We can't change many of those things, not rapidly. But what we can do is we can educate people. And if we can educate regarding those issues, the P's, whether the 20 or 25 D's, the 5 important ones to remember to hang your hat, we will move forward in a big way. You might recall us, I think almost every speaker shared the important pillars. Give antibiotics appropriately. Restore cellular perfusion. In other words, giving fluids plus minus vasopressors and make sure there's adequate source control. Those messages across, and people, even if they're in facilities where they may not have access to all of these, could even get advice or intervene appropriately. We will make massive inroads. Creating awareness is also important. We know from awareness campaigns that have taken place, in fact, largely 7% of the general population know what sepsis means. And after very focused awareness campaigns, that improved to 14%. Had ever even heard. So we need awareness campaigns, we need education, including healthcare providers, and we need to engage with policy stakeholders. And if we do that, we will make roads. There's no question of doubt. That's the best thing that we can do currently, whilst we're working on the infrastructure, the fundings, the inequity elements. If we get that and people implement that, we will move forward and favorably.
Very much. Now, in closing, I think what you've touched on a very important point. It's part of the Global Sepsis Alliance 2030 agenda, and one I would recommend or encourage, if you can go to the site and download it, because it's useful to see what we're trying globally. Now, I'd like to thank bioMaru for sponsoring this seminar. Another important that was touched during the seminar was, I think, Mervyn, you, and I think Alison, was we should never forget the issue of prevention. And we spoke about vaccine, immunization, hand hygiene, deliveries, etc. That should always be in the fore, especially in low and middle countries where resources are less. The other important touch on the issue of getting to medical students, nursing students, etc. And I know bioMaru is sponsoring another seminar on December the 15th that is in conjunction with the Medical Student Association. I would encourage people to attend. Now, nothing has come together without a lot of work in the background. And I'd like to thank Mariam, our CEO, and the office staff, Katya, Simona, who has worked tirelessly to put this all together. I thank all of you, the speakers, who have taken your time to share with us. And I'd like to thank the audience. I think we all lead busy lives, but I'd like to thank the audience for joining us, and I would encourage them forward and in the future join the other webinars. Again, my appreciation for everyone, and wherever you are, it's good morning, good evening, good night. Have a wonderful evening and night, and hope to see you again sometime. Take care. Bye.